Good afternoon, students. Today I'll say about proximal tibia fractures, the comprehensive patient management. Welcome to our presentation on the comprehensive management of proximal tibia fracture. We will explore the journey from initial assessment to long-term rehabilitation. Then first we'll go for anatomy and classification of proximal tibia fracture. Okay. Key anatomy is the proximal tibia is the upper part of the chin bone. Chin bone means the leg medial bone. Okay, the tibial plateau. What is the plateau? The weight bearing surface is articulating with the femur. That is a femur, that is a tibia. The weight bearing surface is articulating with the tibia. Okay, that is a tibial plateau. Meniscal ligaments, the crucial for knee stability and load distribution. The meniscal ligament mainly role for crucial for knee stability and load weight distribution. Okay. Then you go for scratch curve classification. Okay. This system categorizes the fractures based on location, severity, and guiding treatment decision. Okay. First type 1 to 6, the increasing the complexity from simple wedge to bicondylar fractures. Okay, that is indicates the involvement of the articular intra-articular damages of the fracture site. Then we'll go for initial assessment and emergency management principles. Okay, then first rapid evaluation. First assess the ABC. What are the ABC? A means airway, B means breathing, and C means circulation. That is an emergency procedure for it's a trauma department. Then is immediately check for associated injury and neurovascular status. Then pain management, mainly for administrative anesthesia. Anesthesia promote to improve the patient comfort and facilitate the examination. Okay. Then immobilization. What is immobilization? The knee to prevent further displacement and reduce soft tissue damages. Okay. The sprint to knee to prevent further displacement and reduce the soft tissue damages. Then imaging is mainly for the standard X-ray and the CT scan. The normal the extra-articular fracture we'll see about the X-ray anteroposterior view and lateral view. Then intra-articular fractures we'll see about the CT scan MRI. Then further soft tissue injury is seen about the MRI scans. Then we'll go for non-operative versus operative procedures strategies. Okay, the non-operative procedures mainly for the minimally displaced fracture. Minimally displaced fracture, the scratch curve classification type 1 and 2 fractures mainly for non-operative management. It's mainly for minimally displaced fracture. Then you go for stable fracture pattern. Stable fracture pattern. Then patient with the significant comorbidities. Okay, often involves the casting or bracing. Casting or bracing followed by the gradual weight bearing protocol. Then you will go for operative indications. It is mainly for displaced intra-articular fracture. Displaced intra-articular fracture. Then is a fracture is a significant instability. Mainly for type 3 to type 6. Both of the categories mainly for operative findings. Then you open fracture or for neurovascular complications. The aim is to restore the articular concurrence and the stability for optimal functional outcome. Then surgical approaches and fixation technique. The lateral approach is mainly for common for scratcher 1 to 3 fracture, type 1 to type 3 fractures, offering access to the lateral plateau. Okay, then medial approaches used for scratcher fourth type of fracture, addressing the medial plateau fracture. Then dual approaches, bicondylar fractures, that is a type 5 and 6, allowing the comprehensive reduction. Then fixation method, plates and screw commonly used to do the fracture alignment, then restore the anatomical alignment. Then post-operative rehabilitative goal for patient. Immediate post-op will go for pain control, wound care, and the gentle range of motion exercise tolerated. Okay, is a pain control is mainly go for any cryotherapy is application. Then wound care is mainly for proper dressing care. Then proper hygienic and for the mainly wound care. Then gentle range of motion is mainly for the unaffected side limb, is mainly for range of motion exercise done for exercises. Then early rehabilitation mainly focus on the restoring knee flexion and extension. Restoring the knee flexion and extension. The non-weight bearing or partial weight bearing are progressive. Okay. Then we will go for progressive loading. The gradual increase the weight bearing in the strengthening exercise and proper shift training. Okay. Then return to activity. Sport-specific drill and functional training, typically 6 to 12 month post-operative surgery. Will go for sport-specific drill or functional training will go for 6 to 12 months after the surgery. Then potential complications and then management mainly for infections. Risk for open fracture management is mainly for antibiotics, and surgical deployment is mainly one must care. Okay, without care, mainly complication in the fever, the wound infections, the implant failure. These are the most common complications. Then is a non-union or a malunion. The failure to bone heal or improper alignment may require the revision of the surgery. Then post-traumatic arthritis, the common long-term complications due to articular damages. They manage the conservative measures or the arthroplasty. Then neurovascular injury that requires the urgent surgical intervention to prevent irreversible damages. Then we will go for conclusion of the future direction of the patient care. Mainly for key pathway, the proximal tibia fracture demand a structured approach from the diagnosis of the rehabilitation for optimal outcome. Then the personalized care, the treatment plan should be tailored to individual patient needs to fracture characteristics. Then future direction, the advance in the surgical technique, biomaterials and regenerative medicines promise the improved healing and functional recovery. Then robotic assisted surgery and virtual rehabilitation are emerging areas.